nature and the swelling was not reducible.
So you
Now,
say insidious in onset.
yes, sir.
Okay, onset gradual கிடையாது insidious. Insidious opposite என்ன?
Sudden onset.
Sudden. So there are only two onsets. Okay, one is sudden, other is insidious. Progress is gradual or rapid. Okay, okay, right. So the other thing also you mentioned is swelling in the scrotal region on the left side, left side of the scrotal region. So scrotal region under the full that part is called scrotum, either right or left side. Okay, so you make a small corrections of that. Okay, so it is insidious in onset, slowly progressive, correct? Then proceed.
No history of pain, no history of any trauma, no history of
Okay.
sudden increase in size,
Okay.
no history of features suggestive of UTI in the recent past, no history of
Okay.
leg edema,
Okay.
no history of features suggestive of pulmonary or renal tuberculosis, no history of loss of appetite or loss of weight, no
Okay.
history of cough, hemoptysis, no history of any other swelling in the inguinal region.
Okay. Go back and tell me the relevance of each of these complaints which you have tabulated here. Go to the previous slide and the previous one. Yes.
So history of pain is found in epidermoarchitis, therefore it is a differential diagnosis.
Okay. Epidermoarchitis, the swelling will not be very big, which is the other condition where the scrotum is very big at the same time painful.
There can be testicular tumors which can lead to pains.
Not acute pain will be there for testicular tumors.
Hematocele can cause
Hematocele or some other thing will be more painful, infection.
sir, orchitis.
Pyocele.
Pyocele.
Okay. Hematocele will also be painful. It will be tense in the sense. But actually, pus is present means the pain will be extremely high. Okay. Very painful now. Of all the conditions you know, inflammatory conditions produce maximum pain. Okay. Pyocele means infection, pus, frank pus. You love intolerable throbbing pain. Okay. So history of pain in a enlarged scrotum. First, you should say it could be a pyocele. It could also be an orchitis, in which case the swelling will not be very markedly big. It will be a small swelling. Okay. So pain can also be present in other conditions like testicular tumors, but it will be a late presentation. Okay. The first thing which you should come to your mind when it is a painful big swelling is pyocele. Or hematocele can produce pain which will not be as high as a pyocele. Okay. So next line is
history of trauma.
Okay.
It is found in hematocele.
Okay. Then
history of sudden increase in size in case of malignancy in testicular tumors.
Okay. So sudden increase in size over a period of weeks, it is possible in testicular tumor. Sudden increase size within a day means bleeding into a already existing small hydrocele will be there. The patient would have sustained some injury. Within that small hydrocele, there will be a lot of bleeding and the swelling will become very big within a day or within a few hours. Okay, sudden increase in size, the rapidity in which the size increases should be considered in your mind. Okay, sudden increase in a period of week time could be or week or months becoming big. What you said is a possibility. Okay, malignancy becoming rapid within hours, within one day. If it is becoming too big, then you should think of bleeding in an already existing small hydrocele. Okay, right. Next one.
History of UTI is present in epidermoarchitis.
Okay, what is the relevance here?
It can cause swelling, epidermal head swellings.
Okay, okay, the tract is next to that. We'll accept it. Okay, then.
Leg edema is found in case of filariasis.
Which could also be an etiological factor for scrotal swelling. Okay.
And then tuberculosis can lead to tubercular epidermitis, which can lead to
tubercular orchitis causing secondary
swelling.
hydrocele.
Yes.
Okay, right. Then,
History of loss of appetite and loss of weight in malignant conditions.
okay,
And then cough and hemoptysis, any metastatic action of testicular tumors.
okay. Secondary is due to testicular tumor. What is the commonest testicular tumor in which massive hemoptysis and cannon bell secondaries happen?
Seminomas.
Is it?
Seminomas, sir.
It is possible, but there is another tumor which is causing extreme hemoptysis. It is called choriocarcinoma. It is called
Choriocarcinoma.
hurricane tumor.
Hurricane tumor.
Okay,
Yes.
hurricane hurricane எவ்வளோ ஃபாஸ்ட்டாக ப்ளோ ஆகுதோ அந்த மாதிரி it will progress so very rapidly. Right?
Yes.
You will find the testicular swelling, and within a few days the lung will have big metastasis. They call cannonball secondaries. It looks like a cannonball which they used to practice in war in the past time. Cannon for a ball secondaries will be so big and the hemoptysis will be so massive. Okay, all of you remember? Yeah, very rapid, very fast growing and fulminant tumor of the testis which can metastatize to the lungs is choriocarcinoma. It is called hurricane tumor. Okay, right. Next one.
Any lymph nodal involvement, sir? Any swelling in the
Okay,
lymph node?
agreed. Next slide. So you should know the relevance of each of the complaints you are giving out here. Okay, right. Past history.
No history of TB, syphilis, diabetes, hypertension, asthma, and epilepsy. No history of
Okay.
similar complaints in the past.
Okay.
No history of any previous surgery or any intervention.
Okay. Next.
Family history, no history of similar complaints in the family or neighborhood.
Okay.
Summary: a 45-year-old male with chief complaints of painless swelling on left side of scrotum with insidious onset, progressive nature, and which was irreducible. Patient had no other significant history.
Yes.
So I would like to examine the scrotum.
Scrotum for possible benign condition or possible benign condition only you should tell. At a history level, you can just, you may not be able to give a diagnosis, but you will be able to decide whether it is a benign condition or malignant. Suppose the same patient has given 3 months time tumor becoming very big, and the patient is having loss of weight, loss of appetite, hemoptysis, everything is there, then you think possibly of a
Malignant condition.
malignant condition.
Yes.
Okay. You understand what I tell?
Sir.
The same summarization, if it happens to be an elderly man presenting with very rapidly growing tumor within a period of 2 or 3 months associated with extreme loss of weight, loss of appetite, and episodes of hemoptysis with a slowly developing pain also, then you should think of possible malignant lesion in this scrotum. That's how you should rationalize your findings. Okay. Now we will come to examination. So Kaushik is going to examine the scrotal region for a possible benign condition. Okay.
First, general examination. The
Yes.
consent was obtained and examined in well-lit room.
Yes.
Patient was conscious, well-oriented, moderate pupil to nourished, no pallor,
Yes.
no ectras, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy.
Yes.
Vitals BP 120 by 80.
Skip it. Come to local examination.
Local examination.
Yes.
Patient was exposed from umbilicus to mid-thigh and examined in a standing position.
Yes.
Unilateral left-sided scrotal swelling of size 12 into 10 centimeter, ovoid in shape, extending from root to base of scrotum was found. Skin of the swelling is smooth with no rugosities, no redness or edema, no excoriation.
Rugosities is lost
rugosities
completely. Yes. Right. So there could be 3 conditions. Rugosities maintained. Second one is rugosities minimized or rugosities absent. It is a tense hydrocele with a lot of fluid inside. The rugosities may be totally lost. Okay, right.
No blackening, no ulcer, scar, or sinuses.
Okay.
Puffing pulse is absent.
Hmm.
Penis seems to be pushed to the right side.
Hmm. Yes.
Palpation. No warmth or tenderness over the
You will have
swelling.
to mention another thing when you examine a scrotal swelling. Go back. Should you mention any other contour in the swelling? So it's a single swelling, ovoid in shape, 12 cross 12 centimeter size, extending from root to base. Skin of the swelling is normal. Surface appears even or smooth. No redness, no excoriation, no scars, nothing. Cough impulse is absent. Penis seems to be pushed to the right. Anything else you should tell?
No, sir.
You will have to mention about the visibility of testis
Okay.
inspection. All scrotal swellings, right? It could
Yes,
be a
sir.
hydrocele, it could be a complete hernia, it could be incomplete hernia. All these things will present as a scrotal swelling. Am I right?
Yes, sir.
ரைட்டா ஹைட்ரோசிலும் ஸ்க்ரோட்டல் சொல்லிங்க தெரியும் கம்ப்ளீட் ஹைட்ரோசிலும் அப்படிதான் இருக்கும் இன்கம்ப்ளீட் ஹைட்ரோசிலும் இருக்கும் then you should mention the visibility of testis. How
Okay,
you
sir.
should put it? I think most of you forget to mention that in inspection. Testis is separately seen or not, you should put it in inspection. Okay?
Okay, sir.
Testis is not separately visible in this case. Where it will be separately visible?
In case of secondary hydroceles,
Is it? Second hydrocele
in hydrocele of cord,
Huh?
hydrocele of cord, sir.
Hydrocele of the ancestor hydrocele of the cord.
Cord.
I agree. Anything else? Any of you know the answer? You can put it in the chat box. I have already told you when I was telling you about previously. So one is hydrocele which will cause scrotal swelling. What are the other conditions which will cause scrotal swelling? Big one.
Pyocele.
Any other
Hematocele.
condition? Huh?
Hematocele.
Hematocele, pyocele, hydrocele, all these things, the testis will not be seen. Any other condition? Desi Kumar is telling hernia. Do we agree?
Sir.
What hernia?
Indirecting venous hernia.
No, according to the extent you tell me, not anatomical types.
Sir?
See, a hernia presenting in the scrotum, what are the types possible? Up to the superficial ring, up to mid scrotum, up to the bottom of the scrotum. That way you classify. Kumar, I think you can tell me further. You correctly said it's a hernia. Unmute yourself and tell me.
Good evening, sir.
Yes.
I was thinking indirect infant hernia.
Huh?
Direct infant hernia.
Louder, louder, please.
Direct infant hernia.
Direct internal hernia. Okay. So, scrotal swelling can be present in case of two types of hernia. One is incomplete hernia where the fundus of the sac will not come up to the bottom of the scrotum. Kaushik, you understand?
Okay, sir.
That's what I expected from you. You should tell the hernia presenting in a scrotal cavity. It could be an incomplete or a complete. Complete hernia goes up to the bottom of the scrotum. So, எந்த கண்டிஷன்ல testis visible இருக்கும்?
Incomplete hernia.
Incomplete hernia. That's why we wanted you to mention it in your inspection. The testis is separately visible or not. So conditions where yet testis may be separately formed. You will have the swelling in the scrotum. At the bottom you will have another contour or appearance of testis separately. It will be present in an incomplete hernia, number one. And as I have already correctly told, it could also be present in a case of encysted hydrocele of the cord, a big one. Okay, a big encysted hydrocele of the cord also you will have. So what I want you is, when you present a case of hydrocele on inspection, when you finish, you should always tell whether the testis is separately visible or not. Okay,
Okay, sir. Okay.
Kaushik? Okay,
Sir.
right. Yes, proceed.
Palpation. No warmth or tenderness or swelling. Inspectory findings are confirmed. Swelling has smooth surface and firm in consistency. Able to get above the
Firm,
swelling. Fluctuation present.
firm
Brilliantly transilluminant.
inconsistency, you mean?
Sir,
Hydrocele will have a firm consistency.
cystic like
It
firm.
is cystic only. Cystic consistency could be a flabby or tensely cystic. The tense
Yes.
cyst should not be mistaken for firm. Firm consistency means solid tumor. Okay,
Okay, sir.
or a lymph node or a parotid gland enlargement or a thyroid goiter. All these things are solid tumors, which when you palpate will have firm feeling.
Okay, sir.
Anything which is containing liquid will be soft.
Okay.
Soft in consistency, fluctuation reduced and the cystic. Okay,
Cystic.
so
Okay, sir.
you should not mention firm inconsistency. You should tell soft inconsistency and cystic. You can tell. Okay,
Yes, sir.
so hydrocele don't present as firm inconsistency. Firm is for solid swelling.
Okay, sir.
Eh? Okay,
Yes, sir.
then.
And then fluctuation present. Brilliantly transilluminant. Test is
Okay,
not palpable on left side.
okay,
Testicular sensation present.
okay,
Spermatic cord is palpable and appears to be normal.
okay,
Swelling is irreducible. And then
okay,
cuff impulse is absent.
okay,
No palpable lymph nodes.
okay.
Right side of the scrotum and right testis and spermatic cord appears to be normal.
How did you elicit fluctuation in this case?
So you must hold the testis on with both hands and
Yes,
between the thumb and the index finger, and
yes.
must press from one side, and the other side will move. So the side hand.
Okay. What you have told is correct. The word you should use is, I will fix the swelling first. Okay.
Yes.
You fix it with two hands, hold each pole of the, it is ovoid, you know.
Yes.
So you fix, you should answer, I will first fix the swelling using two hands, thumb and first two fingers. Then I will generate impulse on one side and receive it on the other side. Okay.
Okay.
This is for a big swelling.
Yes, sir.
The eliciting of fluctuation is different for a small swelling. For example, it is the size of a lemon only or a gooseberry. இவ்வளோ சின்னதாக இருந்துச்சுன்னா அதுக்கு என்ன மெத்தட் யூஸ் பண்ணணும்?
Within one hand we must 3 fingers you must use and press in the middle.
Yes. So you remember there are three methods of eliciting fluctuation. First one is for a big swelling, where two fingers are used to fix the swelling and generate the impulse with one finger and receive it with the other finger. Right? This is for a big swelling. For a small swelling, you fix the swelling with one hand using the index and thumb like this, and put the index finger of the opposite hand on the summit and press it. Okay. When you press, both the fingers will receive the impulse like this. When you press, it will become like this. Okay. This is for small swellings.
Sir.
For very small swellings, just the size of a 3 centimeters or 4 centimeters only, very small, then you use what is called a Paget's test. Okay. In Paget's test, you need not fix the swelling. It is not possible. It is very small. You use only one finger. Okay.
Yes, sir.
You palpate the summit. You palpate the periphery. கையை வச்சு அந்த கன்சிஸ்டன்சியை ஃபீல் பண்ணணும். If the summit is softer than the periphery, it is cystic. If the periphery is softer than the summit, then it is not cystic. It is not fluctuant. Okay.
Okay, sir.
So all students kindly remember there are three methods of eliciting fluctuation. One for a big swelling, other for a small swelling, and another one for a very small swelling. First one utilizes two hands holding two poles, generate fixing the swelling and generate an impulse and receive it. For a small swelling, you fix it with one hand using two fingers like this. Put a index finger of the opposite hand on the summit and press and receive the impulse like this. Then it is fluctuant. For a very small swelling, use only one finger, palpate the summit, palpate the periphery. If summit is softer than the periphery, it is fluctuant. If the periphery is softer than the summit, then it is not fluctuant. Am I clear?
Okay, sir.
If you have any doubt, you can ask me right now itself regarding fluctuation. In exam, examiners will sometimes ask you, very small swelling na enna பண்ணுவ அப்படினு கேட்டா கரெக்ட்டா சொல்லணும். Page stress sir, you should tell. Okay? So
Okay.
fluctuation you should. What are the fallacies of fluctuation? Fluctuation is meant to diagnose what?
Any fluid filled
Yes,
cystic
the
conditions.
swelling is containing fluid.
Fluid.
When it will not be positive, though fluid is inside, it will not be elicitable. In what condition? Fluctuation. Yes. Anybody can answer? Fallacies we call it. Or there is fluid inside, but fluctuation cannot be elicited. In what condition? Any students are aware of it? So if the cyst is, or if the swelling is tensely cystic, okay, so ஒரு hydrocele அல்லது cyst இருந்ததுன்னா அதில் fluid இருக்கிற குவான்டிட்டியை பொறுத்து it will be flabby. கொஞ்சமா fluid இருந்தால் very flabby. Moderate fluid is there, it is normal cyst. If the liquid is very secretion is more and lot of fluid is there and the cyst becomes very tense. Okay, fluctuation is not elicitable if the hydrocele sac or cyst is very tense. So fluctuation cannot be elicited in a very tense cyst, or it will not also be elicited in a very loose cyst. For suppose cavity is too much and only part of it is filled, then you may not be able to make it fix it. The fluid cannot be transmitted because the amount of fluid is small, less only. The others have been somehow reabsorbed. Okay, so the fallacies of fluctuation are it is not dependable in case of very tense cyst or very lax cyst. Understand?
Yes, sir.
Okay. So உள்ள fluid ரொம்ப அதிகமா இருந்தாலும் fluctuation பண்ண முடியாது. There is no space at all for the fluid to move. It is very tense. If it is very loose also, your impulse will not travel because less fluid is there. Okay, right. Transillumination, where will you keep?
So I must place torch on the lateral side of the discs.
Lateral side of the scrotal swelling. Which area is to be avoided to place the torch?
Posterior must be avoided, sir.
Yes. Reason?
Testis may block the.
Yes, the testis will be intervening and it will block the passage of light beam. So your transillumination examination will be erroneous or not dependable. Okay, so you should always place it. Once again, I tell you, when you go to exam or even for a class, you should always go with the illuminoscope, right? You should prepare a illuminoscope of your own. You come to hospital, you will get lot of X-ray sheets. You roll up nicely one X-ray sheet and put a plaster all around and make it a cylinder. Okay, a opaque cylinder. So it should not transmit the external light. So for exams, you should always come with a torch and a illuminoscope for this purpose. Other cases, you should come prepared like tourniquet, stethoscope, everything. Okay. Next one is testis is not palpable on left side, right?
Okay.
So where did you test for testicular sensation then? You said
Slightly tap on the testis and feel if any sensation is present.
Yes, testis is not palpable means the testis will be there on the posterior aspect. Okay, va?
Okay, sir.
Suppose there is no hydrocele, the testis will be palpable from the anterior aspect. Scrotal swelling, the anterior aspect, you can keep your finger and palpate it. There is lot of fluid there. The fluid comes to the anteriorly and makes it not palpable, but still posteriorly you can palpate the testis. That's where you go and elicit the testicular sensation. Okay, so you should tell testis is not palpable anteriorly because of fluid, but you should go to the posterior aspect where epidermis and testis are present. It's a constant position. The position of testis and epidermis is posteriorly present is a constant position. Any amount of hydrocele present will not affect the posterior placement of the testis. You should go there and test for testicular sensation, right? Okay. Swelling is not reducible. Cough impulse is absent. Right. Next.
Other system examination, CVS SN is heard, no murmur, RS no vesicular, normal vesicular bed sounds heard on both sides. CNS,
Yes.
no focal neurological deficit. Abdomen, soft, non-tender, and no palpable nodes or masses.
Yes.
Summary, the patient a 45-year-old male
Yes.
with swelling on the left side of a scrotum of size 10 into 12 centimeter.
History வேறதெல்லாம் முடிச்சிட்டு வந்தோம் கௌஷிக். You should tell 45-year-old man presenting with left-sided scrotal swelling not preceded by trauma, which is not painless, not with fever, without history of loss of weight, loss of appetite, and no history of hemoptysis. அப்படின்னா essential points in the history you should tell first in the summarization, then you should tell the examination finding, right? Okay.
Yes, sir.
So you have made a diagnosis of, you practice that later.
Okay, sir. Okay, sir.
Presenting with the swelling which is ovoid in shape, getting above the swelling is positive, fluctuant, cough impulse absent, brilliantly transilluminant. And test is not separately seen. I would like to make a diagnosis of left-sided primary vaginal hydrocele, right?
Okay, sir.
So of all the findings you have presented here, what are the cardinal features, 2 or 3 only, which you would like to put forth to confirm that it is a hydrocele? What are the cardinal features?
Sir, able to get above the swelling, sir.
Very good. So the very important cardinal feature of a hydrocele is able to get above the swelling. Then next.
Fluctuant, sir.
Fluctuation.
And then brilliantly transilluminant.
Transilluminant.
And then the swelling was not reducible, sir.
Good. So getting above the swelling, not able to reduce, cough impulse absent. ஏன்னா ஒரே ஒரு differential another swelling which can present similarly is a scrotal hernia. Okay.
Yes, sir.
So a scrotal hernia, you will not be able to get above the swelling.
Yes, sir.
The hernia may be reducible when you slowly try, and expansile cough impulse will be present. இது மூணுமே different இருக்கும் for a hydrocele. That's why you should tell all these things as the cardinal features. Fluctuation அதெல்லாம் அப்புறம் வரும். Okay. Right. Okay. What will you do for the patient?
So investigation,
Yes.
CBC, blood urea, sugar, baseline investigations such as CBC, blood urea, sugar, BTCP, serum creatinine, urine album, sugar, and then
Okay.
ECG and chest X-ray.
Okay.
Specific investigation, we can go for use this scrotum in case of any
What are the
suspicion
findings?
of malignancy.
What would you like to look for in USG?
So if the swelling is cystic or solid in consistency, sir.
Very good.
Sir, in case of any solid consistency, any other lymph nodes involvement, we can look for.
Okay. So, yes,
Any calcification, we can look for, sir.
in the
Scrotum.
scrotum is first. Yes. The main purpose of doing an ultrasonogram of the scrotum in a hydrocele is to rule out testicular malignancy. That is the foremost thing. What happens in testicular malignancy to the shape of the testis? Architecture will be altered. Architecture of the testis is another. Testis should be of a correct elliptical shape with regular borders. Shape should be correct. It should not be irregular. And the margin should be well defined like that. Okay. So correct architecture, now it will be like a small pebble. Okay. An elliptical pebble mark. But in case of a malignancy, it will be distorted. It will be irregular shape. Okay. And the edges will be ragged. The surface of the testis itself, as evidenced by the ultrasonogram, will be altered, uneven arco, nodularities will be present. So the whole thing is mentioned as the architecture of testis is altered in case of malignancy. Not only in malignancy, even in other orchitis like tuberculous orchitis, the testicular architecture will be altered. Okay, you should tell I will do ultrasonogram of the scrotum to look for the hydrocele, confirm hydrocele. Number one, nature of the hydrocele fluid, whether it is clear or turbid or any calcifications are within the hydrocele sac fluid. Next, I would like to see whether architecture of the testis, whether it is maintained or destroyed or altered. If it is altered, you should think of malignancy or orchitis. Okay. So usually main testicular architecture should be looked for. Okay. Any other investigations you will do?
So that's baseline and USG scrotums.
Under specific investigations, if the USG scrotum is abnormal, any other investigation you will do?
So in case of tumor markers, we can look for in case of.
Yes. In your ultrasonogram of the scrotum, if it is architecture is altered, then you will have to go ahead and do a tumor marker. What are the tumor markers you will do for a testicular tumor?
Beta HCG, alpha fetoprotein.
Beta HCG and alpha
fetoprotein.
Fetoproteins. You also do LDH. Okay. So you should know one condition in which the tumor markers will be elevated. Beta HCG will be elevated in what tumor?
Seminomas.
No.
Yolk sac.
Choriocarcinoma.
Okay.
Beta HCG. Okay. Alpha fetoprotein will be elevated in mixed seminomas. Okay. LDH will be elevated in what?
Not sure.
Other tumors like Leydig or sertoli cell tumors, the LDH will be elevated. Okay, one for each. Pure seminomas will not have tumor marker elevation. Mixed seminomas, alpha fetoprotein. Okay, and in case of the other one, beta HCG is very classical and it is very specific for choriocarcinoma only. Okay, right. Then.
And then treatment.
Next. Yes.
We can do Jabalist procedure.
Why do you want to do treatment for this case? Why do you want to surgically treat the case? Your option is to do surgery, right?
Yes, sir.
Why do you want to do surgery for this patient who is having hydrocele?
Sir, if the patient feels if the swelling is uncomfortable or uncosmetic, we can go for a procedure, sir.
Very good. Is that the only one indication?
No, in case if it causes any symptoms, and in case of any armed forces.
I have told 3 indications for all surgeries. நீ ஒரு சர்ஜரி பண்ண போகணும்னா 3 பர்பஸ்க்காக பண்ணுவோம் mostly for any disease. The first and foremost is what I've already discussed. I think many of you can put. If you don't operate, what will happen in most of the cases?
Complications.
The first and foremost indication for surgery is to avoid future complications should be your answer.
Okay, sir.
Okay, why do you want to do surgery in ஒருத்தவங்க கேட்டாங்கன்னா surgeon in most of the cases, more than 90-95% of the cases, it will be to avoid future complications, number one. Second one is cosmetic purpose. Okay, the patient is wearing pants, he will be embarrassed to see that it is unsightly. Okay, cosmetic reasons. Third one is mechanical hindrance. For all cases, these are all the three indications. Mostly it will be complications only, to avoid complications. In hydrocele and in some lipoma or goiter, sometimes it will be done for cosmetic purpose. It is acceptable. Okay, so here hydrocele is prone to develop many complications. What are the complications of hydrocele, untreated hydrocele?
So hydrocele can go for rupture.
Yes.
Any infection may lead to formation of piocele.
Very good. Infection, injury,
and then any atrophy of testis can occur in long life.
Testicular atrophy, degeneration. So injury can occur in hydrocele because it is a big one. When the patient is riding a bicycle or a bike, goes and travels in a rough road, a jump or jolt can injure it, and the patient will injury to hydrocele will result in what condition? Roshi?
Sir, any hematocele formation.
Good. ஒரு ஹைட்ரோசெல்ல இன்ஜுரி ஆச்சுன்னா ஹெமட்டோசெல் ஆகும். ஹெமட்டோசெல் may further go on to form a piocele. First blood ஆகலாம், blood infect ஆச்சுன்னா piocele ஆக சான்ஸ் உண்டு. Then testicular degeneration will be there, necrosis, everything. Okay, that is regarding injury. An infection can occur even without any injury, in which case the patient will go in for piocele right away. Hydrocele clear fluid இருந்தது, அது it will become piocele. Okay, then an injury can cause to rupture of the hydrocele. Okay, right. Then so due to avoid all these conditions, you are doing a surgical intervention. So what are the surgeries there?
Jabulase procedure, Lord's plication, and then hydrocelectomy.
Where do you do Lord's plication? Where do you do Jabulase?
In case of small hydroceles, we can go for Lord's plication.
Okay. So for this case, 10 into 12 is a big one, you know.
Yes, sir.
And the fluctuation is positive and Transillumination is brilliantly positive, means the sac wall is thin only. It is a big hydrocele but thin sac wall. You should do a eversion, Jabulase eversion of sac. Okay? So kindly remember there are totally 4 interventions for hydrocele. Number 1 is very small hydrocele with very thin sac. You do only plication. Plication means you put an incision anteriorly, open up and define the hydrocele sac from anterior only. You will not dissect extensively and deliver the sac here. You will just expose the anterior part of the tunica vaginalis and incise it, let the fluid out and put a suture and plicate it. Or frill mari edges மட்டும் surrounding layers ஓட போட்டு stitch பண்ணி விடணும். That is called Lord's plication. Okay, in Lord's plication is done for small hydrocele with a very thin sac. You do not dissect out the hydrocele completely, only the anterior part is exposed and incise fluid let out and the edges are plicated with the surrounding or overlying layers of the scrotum. Okay, this is for very small hydrocele. For a moderate hydrocele or a big hydrocele with a thin sac wall, you do Jabulase eversion, which is the commonly done surgery for most of the hydrocele. So here you incise all the layers, identify the tunica vaginalis layer, separate it throughout, deliver the hydrocele sac out of the wound, then incise, let out the fluid and evert So உள்ள testis வெளியே வந்துடணும். The cut end will go at the back posteriorly and suture it with what suture, Kaushik?
Sir, non-absorbable sutures, permanent sutures.
Absorbable suture.
Absorbable.
Okay, non-absorbable na protein, silk, இதெல்லாம் non-absorbable. You should not use it for a eversion. You should use a catgut or a vicryl, which is absorbable. You will do a suture and after some time it will be digested by the body fluids and will vanish. That's why it's called, it is absorbed within the body system. You should use a absorbable suture only for eversion sac suture. Okay?
Okay, sir.
Right. So that is called jabless eversion. Then the third condition is there, a big hydrocele with a very thick sac. Okay? Even last week we operated on hydrocele where the sac was very thick. It will be like a leather. நம்ம ஷூவோட லெதர் இருக்குல்ல அந்த மாதிரி இருக்கும். In which case you cannot evert it. Evert பண்ணவே முடியாது. Very hard. In that case you do what a procedure called?
Excision of sacs.
Subtotal excision. Okay?
Yes, sir.
The testis will be there in the posterior aspect of the hydrocele sac. You keep it there and surrounding the testis you leave a rim of sac wall. Rim na evladhu for 1.5 centimeter or 2 centimeters of sac will be left surrounding the testis and rest of the cyst wall you excise and throw away. And the cut edge you will suture using non-absorbable interlocking sutures. ஒவ்வொரு சுச்சருக்கும் லாக் பண்ணி பண்ணணும் because the edges are likely to bleed. Okay, so you put continuous locking sutures after excise, subtotally excising the sac. Okay, this is for the third condition. The fourth one is complicated hydrocele. Hydrocele where there is ametocele or pyocele and the testis is totally atrophic or necrose. In which condition, what is the surgery you will do?
Orchidectomy.
What orchidectomy?
Total orchidectomy.
Low orchidectomy. LOW. Okay? Low orchidectomy is done at the level of the root of scrotum. Okay. There is another orchidectomy called low opposite in that. High orchidectomy. Where is it done? Deep inguinal ring. Card வருது இல்லையா டெஸ்டிஸ்ல கார்டு தானே வரும் வாஸ் டிஃபரன்ஸ் இட் வில் கோ தேர் யூ வில் டூ இட் யூ வில் கட் இட் அட் தி deep ring level, deep inguinal ring. The incision will be inguinal only, otherwise it is called inguinal orchidectomy. High orchidectomy is done for what condition?
In undescended testis which
no testicular tumor. High orchidectomy, or it is called otherwise it is called inguinal orchidectomy, high orchidectomy or radical orchidectomy ன்னு சொல்லுவாங்க. ரைட்டா?
Okay.
The only condition for which high orchidectomy is done is testicular tumor.
Okay.
Where you should not put a scrotal incision. You should put an inguinal incision and deliver the testis from there and cut it at the deep ring level itself. Okay. Coming back to our subject, there are 4 surgeries for all hydrocele cases. Very small, thin walled hydrocele, you do Lord's fluctuation. Yeah. Big size hydrocele with a thin wall, you do a jabless eversion. A big hydrocele with very thick sac wall, you do subtotal excision. And complicated hydrocele, you do low orchidectomy. You understand? There are 4 surgeries you should mention. Okay. Right. How will you prepare the patient for surgery and do it? Tell me. Remember 5 Romans I have told you. Proceed and tell.
So we must make the patient anesthetically fit.
Good.
And then anesthesia, local anesthesia.
You don't have local anesthesia itself. You can do, but the anesthesia which we are using in our hospital for hydrocele is
endotracheal.
Spinal anesthesia. Right? Umbilicus கீழ இருக்கிற பார்ட்டுக்குலாம் பண்றது will do a spinal anesthesia.
Okay, sir.
needle put பண்றாங்கல்ல, usually for hernia, hydrocele, hemorrhoids. For all surgeries below the umbilicus, we usually do under spinal anesthesia. And this hydrocele is very big. You may not be able to give local anesthesia for the whole length. It will be painful. It will not be enough.
Okay, sir.
Understand?
Yes, sir.
So the anesthesia is spinal anesthesia. So you will make the patient anesthetic fit under spinal anesthesia. Yes, proceed.
And then positions,
Yes, what is the position?
supine position.
Good. Then,
And then aseptic precaution.
yes.
And then incisions.
What is the incision?
2 centimeter lateral to the midline traphe.
Yes, it is called a vertical scrotal incision. Vertical scrotal incision.
Okay, sir.
Left sided. Okay, right.
Yes, sir.
What are the layers of the scrotum you open?
First, skin, subcutaneous tissue, and
Yes.
then dartos muscle,
Yes.
external spermatic fascia, cremastic fascia, internal spermatic fascia,
Yes.
and then parietal layer of tunica vaginalis.
How will you know that you have reached the tunica vaginalis?
Not sure, sir.
What makes you think that yes, I am at tunica vaginalis? By looking.
Bluish color.
The moment you reach that tunica vaginalis, the swelling will have a blue tinge, bluish appearance. Then you make sure that you are at the tunica vaginalis, right? Okay. Then these are all the layers. Then parietal layer. Then next, tell me.
And then visceral layer of tunica vaginalis. You must go up to the parietal layer of tunica vaginalis.
Do an eversion of the side. The material you use for eversion, as I told, is absorbable suture material.
Okay, sir.
What is absorbable suture material? You know, commonly
Catgut.
catgut or vicryl they call.
Vicryl, yes, sir.
Vicryl. Vicryl. The chemical name for vicryl is polyglactan.
Okay, sir.
Polyglactan. 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 Okay. So use that only. So okay. What are the other types of hydroceles? You know.
Sir,
What are the types of hydroceles? Tell me.
first, congenital and acquired, sir.
Yes, very good. What is the treatment for congenital hydrocele?
Herniatomy with excision.
Herniatomy. What is the embryogenic structure behind the formation of congenital hydrocele?
The patent processes vaginalis, sir.
Very good. The process vaginalis is not obliterated, it is becoming patent. The surgery you do for a congenital hydrocele is herniatomy. Okay,
Yes.
right. Any other hydrocele you know?
And then primary vaginal hydrocele.
Good.
And then secondary hydrocele, which may be caused due to
Yes.
tumor.
When will you think of a hydrocele, secondary hydrocele? What are the causes?
Any inflammation,
Yes.
any infection, and then trauma and then tumor.
What are the infections which you know which can cause secondary hydrocele?
The chlamydia infection in younger patients.
In India, what is the commonest infection causing secondary hydrocele?
Gonorrhea, sir. TB, sir.
Tuberculosis. It is very rampant in India, very common. Okay? இந்த மாதிரி ஏதாவது ஒரு காமனான கொஸ்டின் சொன்னாங்கன்னா மோஸ்ட்லி டியூபர்குலோசிஸ் சொன்னா யூ வில் பி ஆல்மோஸ்ட் கரெக்ட் இன் இந்தியன் சினாரியோ ரைட் ஸோ டியூபர்குலோஸ் ஆர்த்ரைட்டிஸ் can cause secondary hydrocele. Okay. Then malignancy also can cause secondary hydrocele sometimes. Okay. So what is called hydrocele of the hernial sac?
Hydrocele of in case of a fluid accumulation in indirect inguinal hernia.
Yes, when you operate for a hernia, you sometimes you do not remove the full sac. You leave behind some sac which is in the scrotum. You partly excise the proximal sac, go and do transfixation at the deep ring and leave a part of the sac, distal sac into the scrotum. Sometimes the cut endeds will unite, cross unite and cause fluid collection in it, which is called hydrocele of the hernial sac. Okay, right. What are the conditions where a transillumination will be negative?
So if the fluid is turbid, like in case of
Turbid.
variaces,
Yes.
in
Conditions:
pyocele, hematocele conditions.
hematocele will be negatively transilluminant and pyocele will be negatively transilluminant. Okay,
Yes, sir.
right. Um, I think we have discussed almost everything. Only thing is you will have to know a few things about common things about testicular tumors. Okay, germ cell tumors, non-germ cell tumors. You will have to know a bit about testicular tumors. They may ask you. Otherwise, routinely asked questions are what we have discussed. Any doubt, you can come out. Other students, if you have any clarification, you can ask me. I'll wait for a few minutes. Kaushik, you have any doubt?
No, sir.
No doubt at all. Okay. Okay then. Right. So
Thank you,
the
sir.
next class will be on Monday, right?
Yes, sir.
You discuss among yourselves and tell me which topic we can discuss. We'll discuss. Someone was asking about